So for the next session, what we're going to talk about is lymphatic surgery. Before we jump into lymphatic surgery, I hope you're seeing through yesterday and today how easy my job is. I'm literally surrounded by team members who are smarter than me, more articulate, and just passionate about what we do. I also want to, along those lines, give a shout out to two individuals, Lisa Palin and Kathy Holly, who are here. I don't see Lisa in the room, but these two individuals are the staunchest patient advocates for lymphedema in Boston and Massachusetts. Lisa and Kathy have been integral in our symposium in years past. They've run the symposium in years past. They were prior LE&RN MASH chapter chairs here in Massachusetts, and each of them has impacted me professionally and personally. Kathy is a seasoned nurse in the OR at MGH, so she was teaching me when I was a resident coming through. And Lisa Palin volunteers her time. She's an accountant, and she volunteers her time to oversee the symposium finances, and she makes sure I don't go to jail at the end of every year. So to both of you, thank you very much for your support.
Thank you, and Dr. Singhal, I moved 13 pounds of fat from my leg.
So I want to talk about surgical options, and as we start here, I want to be clear, and we say this, it's almost the first words out of my mouth in any patient that comes to the door is, we don't have a cure in 2023. And I don't say that to hurt the patient. They need to hear that, because then we start from that baseline. Okay, we don't have a cure, but what can we do to help you? And there are things we can do to help our patients. All right, so briefly I'm going to talk about the center. I'm going to use a train analogy, and we're going to talk about that for a minute when I get there to talk about lymphedema. And I'm not doing that to belittle anybody in this room about lymphedema. You all know what lymphedema is, but it's a cool way to talk to patients about it. And so I'm going to go through that, and then I'll use that as an analogy to talk about our surgical options, prevention, and make some concluding remarks. Again, I do plan on ending early on this so that we have time for questions as we go. Again, our center was established in 2016. We are patient-oriented and multidisciplinary. Multidisciplinary, I think you can already see that with everyone who's getting up here talking about what they do within the team. But patient-oriented goes back to how I started. We have no cure for this disease today. So if we don't have a cure, you better spend time talking to your patients to say, why did you travel to the Boston Lymphatic Center? What are you looking for us to accomplish? And if the next things out of their mouth are a cure, it's our obligation to tell them, sorry, we don't have that. And if you don't want to stay with us, no problem. But if they can help us identify where we can improve their quality of life, then let's go, let's move forward, and this is going to be a meaningful relationship. And what I would like to impart over the course of this talk is for you to know, where are those places where we can impact their life, so you can help guide patients, again, being in the front lines when they come to see you. But if you're ever not sure, just send them, and we'll figure it out with them. I just saw the number, it was 2,905 new patients for treatment or prevention of lymphedema over the last 7 years, and that was as of September 30th. All right, so this is our core team, and again, you're hearing people talk from the team. This is our core team. We have our surgery up top, the lymphatic surgeon, and that soon in the coming year is going to change in terms of we're going to be adding. Currently, we have a lymphatic surgery fellow. We had a fellow last year from England. Our fellow this year comes from Tokyo and is Yuma Fuse, and he actually has a lot of experience in lymphatics. Sarah's our lead nurse. And then we have Tilly, who's our nurse practitioner on the lymphatic side, and on the lymphatic surgery side, and Wei is our database manager. I don't think Katya is here. Leo has actually left us. He's remained part of our program. He still comes in. He's gone over to MGH. He's been an integral part of our lymphatic imaging team for the last 7 years, but he still works with us. Katya De Pepe is taking over his role, and she's already submitted a grant on lymphatics to the NIH in the short time she's been with us. So we're very excited about her up-and-coming contributions to the team. Kevin already spoke earlier today. He runs nuclear medicine. And then Jeff is from IR, and we talked about what he's doing in terms of looking at central potential targets. So actually, this triad right here, this is our imaging triad, and they are our eyes and ears. And then you have your clinical triad, which is right here. So I introduced surgery. Workhorses are our therapists. So Kathy, Emily, Katrina, they run our outpatient therapy division, what we call our lymphatic treatment clinic. And then Tegan has overseen for years and now passed on to Jackie, our inpatient therapy team. So all of our patients who have surgery, they are met in the recovery room by our therapy team, and they are met every day post-op by our therapy team to make sure they're progressing well through their post-operative course. And then, of course, you all heard from Dr. Carroll, who runs lymphatic medicine alongside Betsy, who really, if you think about the workhorses of our center, it's right here and right here. And what's really amazing is we've developed an actual clinic space where they can all be co-located and see patients together. And then, we have a big team, and you got to know how to work together. So we have algorithms, and Brett went over this very well. But basically, we're either treating lymphedema or preventing lymphedema. And if we're preventing, these patients have to move very quickly because they have metastatic cancer, and their surgical oncologist wants us available at the time of their nodal dissection. So they move through this sequence very quickly. Versus if they're a chronic lymphedema patient, it's a little more of an elective patient, we have time to work them through lymphatic medicine or lymphatic treatment clinic, and then eventually they get to a lymphatic surgery evaluation if appropriate. And this is what we looked like pre-COVID. We would meet like this, 7 a.m. on Fridays, I remember. We would meet in person, all sit, review all the imaging together, and make decisions as a team. Today, this is how we do it. We actually still meet in person once a week. I'm sorry, we still meet in person once a month, but the other 3 weeks, we do it virtually. I hope one day we can all go back to being in person for all of them. This is a 1-minute clip. We're gonna do this at much more in-depth later this afternoon. Kathy's put together a mock board, just like what we do for our patients later in the day. But I wanna show you this 1-minute clip, which will just give you a snippet of how we go through a patient. Morning, everyone. Let's go ahead and get started. Sarah, who's our first patient?
Miss Jean Doe.
So I saw Miss Doe. She's a 44-year-old female who's presenting with left upper extremity edema. So her goal of treatment is to decrease the size of her arm and more easily fit into clothing.
She's in compression 168 hours a week, wearing a daytime sleeve, ready wrap at night, and using a pump 1 hour a day. Her LDEX is 6.6.
You can see that there's already a moderate degree of edema, subcutaneous edema along the upper portion of the left upper arm.
At 1 hour, we do have a lymph node showing up in the right axilla.
Here's the radial injection site, the linear channel initially after injecting that travels about midway up and then into that area of stardust disease there.
We'll continue with our Q3 month surveillance visits. We'll see her in 3 months. And again, we're going to go through this in much more depth. I just wanted to see how we all kind of work together in thinking through our patients. All right, so understanding lymphedema, keeping the train on track. So the analogy I love to use for lymphedema is trains. And I think I'm always going to show this because it just brings a lot of clarity, even for me, after all these years of working on this. I always go back to my train analogy because it helps me think through issues. And I want to call out Megan Bellinger, who's here, who helped bring this analogy to life. I pieced together stuff off the internet and put this together in the past. And I think it was 2018, we were at the LE&RN CME event, and Megan came up to me and she basically, many of you may know Megan. She's a CLT. She's incredible here in Massachusetts, and she's a cartoon artist. And she said, let's bring this to life. And we did. It's a book. We were giving it out, and then we got so many requests for it that Megan put it on Amazon. So we are charging just fee, and I think we make 22 cents per book. We had to, because of some rule. We had to make something off it, but we just want people to have access to it if you find it helpful. So the analogy goes like this. I tell patients, and this is how I talk to patients. I say, look, imagine your heart's the biggest train station in the world, and you've got train tracks coming off it that go to all parts of your body, and your heart is the biggest train station in your body. And here are the train tracks. They go all over your body. And for this analogy, let's just focus on the left upper extremity. So what happens is 9 o'clock in the morning, a big red train leaves, destined for the left upper extremity. It's chock full of passengers. And here's that train, all aboard. It's at the heart. You can see it says left arm and hand. All the passengers are getting on. Well, train takes off. It makes its way down to the end of the left upper extremity. All the passengers have gone off. And 5 o'clock whistle hits. Everyone wants to go home. So the red train's been there, dropped off all the passengers. It's now 5 o'clock. Passengers get to the train station. There's 2 trains that come home, a green train and a blue train. The key concept being both trains have to be working and be on time for there to be enough seats for those morning passengers to get home. 5 o'clock whistle hits, those trains make it home. Everyone's happy. They never even knew they had trains in their body. But what happens when this happens and the train comes off the track? Well, actually what happens is you see all those passengers, and they're doing what most of us would do if we missed a plane or a train. They just kind of hang out and wait for the next train. But what if that next train's not coming? Well, then they might get a little upset and angry and riot. And that's actually what happens in lymphedema, right? Most patients who have lymphedema don't even know it at first. They're in a latent phase, and then something sends them over the edge. And so that's the analogy. The book goes into more of the analogy, and I'll intersperse some more panels as we go through. But again, I just want to say all the humor and laughter is really thanks to Megan and the great work she did in bringing this to life. Okay, so surgical options for the treatment of lymphedema. So we're back at this algorithm, and now we're just going to focus here on lymphatic surgery. So we're going to bring that to the forefront here, and we're going to talk about our algorithm. So this is our algorithm, and so we do our entire workup, and we've gone through a lot of that already. And we basically decide, are they fluid dominant or fat dominant? It's a little bit of a misnomer, because I just want to be clear. When we say they're fat dominant, they still have fluid, okay? But they also have significant fat hypertrophy. And based on this, this is our big decision tree on how we're going to move forward. In our center, we believe if somebody is fat dominant, and just to be clear, 80% of all patients, primary or secondary, doesn't matter, come in with fat dominant disease, right? So when you've been squeezing on your patients and they're getting frustrated with you because you're like, I'm not getting any smaller, it's because you're probably pushing on fat, and especially if you don't have pitting edema. So if they're fat dominant, what we do is we're going to go into bulk them first, put them into our surveillance program, wait 1 or 2 years because they will continue to shrink off the debulking program for about 1 or 2 years. And then, in essence, the way we think about it is we've converted them to fluid dominant disease, and now we're going to go down this pathway. If, as we go down this pathway, if we go down this pathway, and the gentleman earlier asked the question how we decide on lymphovenous bypass or not, this is it. If we see channels on ICG and then we get confirmation with high frequency ultrasound that we have a target vein nearby, that's going to be our target for lymphovenous bypass. So that's how we decide, lymphovenous bypass or lymph node transplant, and that's how we do our decision making. Now, if they come in fluid dominant, we go right down this pathway and we ignore the fat dominant side. Okay, so let's start off. We're going to talk about the physiologic procedures. Physiologic procedures. So if there's 2 takeaway slides, this is one of them. The important thing, and we drive this home with our patients with physiologic procedures, the reason to do a physiologic procedure is you want to decrease the need for therapy, you want to improve symptoms, this is the heaviness, achiness, tightness the patients will acknowledge, and you want to decrease the risk of infection. The big drawback of physiologic procedures is their volume improvement is modest. The way I describe it to patients is if I take a picture of your limb before and after surgery, the only difference you'll tell me you see is the scar I put on you to do that physiologic procedure. You'll feel better, likely, but you won't notice much of a difference in terms of the appearance. So going back to the train analogy, your train's broken, and what we're doing here is we're actually taking a healthy train elsewhere in the body. Here we're taking it from the belly and we're putting it into the arm where you have the broken train. That's what a lymph node transplant is. And this is more of a medical schematic showing what we're doing. Here we're taking lymph nodes from the groin area and we're moving it into the wrist of an upper extremity that has lymphedema. So how does this work? So the way it works is it works as a sump pump. So what's been shown is if you can get those lymph nodes in, and this is not like a 15-minute case, this is about a 9-hour case for a lower extremity, it's about a 6 to 7 hour case for an upper extremity, is you're bringing in lymph nodes and you're getting them to live. And the way you do that is you have to do microscopic connections between really small arteries and veins. And if those connections go down, that lymph node transplant will die. And patient will be okay, but that you basically didn't do anything in doing the transplant. And if you can get that transplant to live, what's going to happen is that lymph node is going to create its own lymphatic channels. It's going to suck in fluid. It's going to be a sump pump, and it's going to clear fluid via the venous system. So it basically reroutes the fluid back into the venous system. So we've written our technique for doing this. We use the omentum. So there's a lot of sites where you can go and get lymph nodes. I'm happy to go into that in Q&A or if people have questions about that. But the one site we know we cannot cause lymphedema is if we take it off the stomach. And it's off the omentum, off these vessels we call the gastroepiploic vessels. So this is what we do. This is just a schematic to show you what we do. We'll go find one of the main vessels in the arm. We'll go into the belly, get this piece of fat, which has lymph nodes in it. Leo would actually come in, and now Katya comes in. We'll do an ultrasound on the table, find the lymph nodes in the fat, and make sure we have them included in a flap. And then this is what it looks like. You take this piece of fat right here, it's 12 by 3 centimeters. It's usually got 6 lymph nodes on average, and we do all these small arterial and venous connections to keep it alive. So this is what it looks like in real life. If anybody gets squeamish, we are going to be seeing some intra-op photos now for a little bit. So this is coming right off the stomach. There's you can see all the lymph nodes here that were found by Leo when he did his ultrasound. You can see it's only 26 grams, so it's pretty small. And this is the forearm here, hands over here, elbows over here, and we're putting it in after we made all our connections. And here's what an early post-op patient would look like. Right here, you can see the incision. And so these are lymphoscintigraphies now, many years out. It takes a while for this. This is a regenerative process. So when patients get to this phase where they're getting a transplant, we warn them, you gotta understand, this is gonna take years. But most of us, we know that there are no lymph nodes in the actual forearm. And you can see right here, transplanted nodes in a patient where we did an upper extremity lymph node transplant to the forearm, injected technetium in the hand, and you can see uptake in the lymph nodes. It's almost as if Kevin drew those in, and I asked him if he did. He said he did it. So those are actual lymph nodes that are alive and working. And so I want to show you what we do in the lower extremity. It's the same idea. Another case, 35 grams, 7 lymph nodes. And here we flip the patient over, open up behind the knee, and we actually go in. Those are the heads of the gastroc right there. We take out the medial popliteal fat pad. The reason we take out things is because we need to make room for the flap. Even though it's only 20, 30 grams, you don't have a lot of room in these areas. So that's why we do that. So we take out that fat pad, and then we actually take out the head of the medial gastroc, just a superficial head. Patients don't even know they're missing it. And then we plug in our transplant there. And here you can see a patient, again, after multiple years coming in and you can see they're transplanted nodes. And you'll notice we put the nodes on the medial side, the medial gastroc, medial side of the leg, because that's where the main lymphatic pathways of the leg run. All right, so the next procedure we perform are lymphovenous bypass procedures. And that is where, again, going back to your broken green train, what do we do with it? Well, what if we can reroute that train onto the blue train tract system, which is the veins, right? Red trains are arteries, blue trains are veins, green trains are lymphatics. And this is more of a medical diagram showing what that looks like, is where we're rerouting, literally cutting the lymphatic and putting it into a vein. So this is ICG lymphography. You guys have already seen a lot of this, but just in our clinic, we're looking at a forearm here. You can see a diffuse stardust pattern. And then you can see as we get more proximal, there you go. You can see a linear pattern, right? So that's an area we get very interested in now. Wherever we see this linear go into disease is a potential area where we're going to target for surgery to go bypass that lymphatic away from the backflow. And this is just what it looks like. So you can see these are small. So every square here is a 1 by 1 millimeter square. So you can see here we're about a 0.3, 0.4 millimeter anastomosis between the lymphatics and the veins. And you can also do a technique where you take multiple lymphatics and put it into one vein. And you know, the data on this, if you look at just the meta-analysis looking throughout the world's literature, you can see that from a subjective improvement, most patients are going to tell you they feel better after these procedures. And I would say that's more or less true. The one procedure where, you know, maybe not, it's a little more hit or miss are the lymphovenous bypasses. We've had patients come in who say, I'm cured, and they actually do look cured. And I want to say that's the rare exception. And then you have patients who came in and say, I feel like you did nothing to me other than put an incision on me. And this is where I think our lymphatic anatomy research will one day really make us more precise in understanding. Maybe we saw a good target, but maybe that's not where we should have been. Maybe we should have been farther up the arm, or, you know, on the lateral side or something like that. So that's where I think our anatomy research will be very powerful. And then so you get a lot of patients saying they have a subjective improvement. I think these numbers are inflated, and generally, I think within lymphatic surgeons, we would agree with that. I would not say 78% of patients are able to discontinue therapy after lymph node transplant. We recently looked at our upper extremity experience, which we published, and 14% of our patients were able to discontinue compression, 1-4, were able to discontinue compression completely after a lymph node transplant and maintain like a 0% volume difference. So we debulked them, and then we did a transplant, and only 14% were able to do that. That said, the overwhelming majority are able to wean either the level of compression or time in compression, but to get to cure, these numbers are a bit inflated. Okay. All right, so that is an overview of physiologic procedures. And now the second slide I really want you to pay attention to is the takeaways on debulking procedures. So with debulking procedures or excisional procedures, the takeaways are you're going to get the wow effect, you're going to get significant volume change, you're going to get symptom improvement, and you're going to get decreased risk of infection. The big drawback is you are required to remain in 24/7 compression in order to maintain these results. So you've maybe seen though, this is what we tell our patients, but obviously we do this in a staged fashion. So we start with this if they're fat dominant, but then the ultimate goal is to decrease their compression. But we don't give any guarantees on that. All right, so excisional procedures, there's your broken train, and here we are getting rid of the passengers, but I really want you to pay attention to this. The train's still broken back here, okay? So we make that very clear to patients with excisional surgeries. We're just going in to remove the fat, but your train is still broken. Now, I know James spoke to you yesterday that there is exciting data saying that maybe we are fixing that train a little bit when we go in and do these excisional procedures, and we are seeing changes in our ICG lymphographies, and I think our colleagues are also seeing this in Sydney as well. So more to come on this, but as far as how we counsel patients is, when we do a debulking surgery, we are not fixing your lymphatic system. We're getting rid of the stranded passengers. So historically, the way this was done was something called a Charles procedure or a Sistrunk procedure. Thankfully, in our 7 years, we haven't done a single case of this. We do have 1 or 2 patients we are likely going to be offering this to, but thankfully, because now there are lymphatic centers, patients usually do not get to this point. So I just want to show you how we do it, kind of the modern day. This is a woman with left upper extremity, breast cancer-related lymphedema, 51% volume difference, LDEX of 63. This is a slide Håkan Borsen, who taught me really everything I know about debulking surgery. He and has also played a big role with Luis and their team. And Macquarie, this is his slide where he showed that in patients who had lymphedema and then passed, and they were able to evaluate their bodies, you can see all the fat hypertrophy that occurred on the side that had the lymphedema. So we go in and we use a technique that really Borsen championed. This is not cosmetic lipo. This is an aggressive surgery. I'm usually soaked in sweat, my fellow soaked in sweat when we do this, especially if it's a male, especially depending on the level of fibrosis. This is a hard operation, but we take out liters of fat when we go in, and the goal is always to make that leg or arm smaller than the other side, because my ultimate goal is for that patient to be able to wear their compression and still put on a leather jacket or still put on ski pants or whatever tight clothing they want. It's such a big part of our moral human fabric is to be able to walk into a store and buy clothing. And that is not a big thing. That is something we need to deliver to our patients, and we know how to do that today. And so our goal is to get the arm or leg smaller than the other side, if at all possible. We use specialized equipment to do this. We do use power-assisted liposuction to do this, and this is what she can look like. Pre-op, 51% difference, 1 year post-op, 5% difference. And this is a lower extremity patient who had a 56% volume difference, LDEX of 116. And then this is how he looked at 1 year with a -8% volume difference and an LDEX of 37. And so we've written about our results doing this in Annals of Surgery. And you can see where this is for upper extremity lymphedema, where 0 represents the other side, where they start off with almost a liter average difference, how over time we can get them down to about 0. This is lower extremity where it's a 3 to 4 liter difference. And again, we can get most of our patients down to about 0. The patients we struggle with are male patients, elevated BMI, even though we have a cutoff of 35, higher BMIs we still struggle with, and primary. So those are like kind of the 3 hits, and I warn those patients we're going to struggle with this a little more than others, but I think each one kind of can become additive. Quality of life scores, we've noticed that there are absolute ceilings to this, meaning blue represents a patient's quality of life score pre, and green represents what happened post-op. So somebody who comes in with a lower score is going to do better relatively than a patient who comes in with a higher score to begin with. But I think you can see the majority of patients do get better, and that's upper and lower extremity. All right, and then briefly want to talk about the surgical prevention of lymphedema. Now, I already went over a bunch of this in the first talk as a lead-in to understand how we got into anatomical research. So I'm going to skip through a lot of those slides unless there are questions about it. But again, we're now switching over to the other side of our algorithm of how we work as a team. And I do want to stop for a moment and talk about Dr. Klimberg. Dr. Klimberg is a breast surgeon. She actually started down this idea of surgical prevention, noting that removal of lymph nodes was the #1 cause of lymphedema. She is the one that said actually initially we should inject blue dye in the arm. But what she said was leave the blue lymph nodes behind because they're draining the arm and not the breast, and then you're going to reduce the rate of lymphedema. And she was absolutely right. So she went in as a breast surgeon, she left these blue lymph nodes behind, took out all of these, and the rates of lymphedema went down to single digits. Anybody know what the problem was? Yeah, those blue lymph nodes unfortunately can harbor metastatic breast cancer. So the oncologic safety of that was challenged, and that's what led Boccardo and Campisi which was the paper I showed from 2009 in Italy, to say, time out, we have skills as microsurgeons to go in and reroute the lymphatic system. But it all started with Klimberg. And then I already told you what Picardo and Campisi did. This is what Megan put together as we thought about what this looks like with our train analogy, is where you know you're about to do this to your train track system, so why don't you reroute it in real time? And this is an older video we have of this, but it's a short one, so I wanted to use this one where I'll show you what we do. This woman's about to get an axe dissection. We inject fluorescein in the arm. You're looking in the arm now, and the arm is to your left, head's up top. We turn on a special filter in our microscope, and so these are the lymph nodes. Here are the arm lymphatics coming right in. So the breast surgeon removes the lymph nodes, we come back, and you can see the areas of damage. There's 2 areas where the lymphatics were damaged. You can see arm lymph just leaking right in there. So what we do is we basically isolate these channels. We put them into a vein. So these channels are 0.2 to 0.8 millimeters. We put them in. We do it a little differently, but conceptually, this is what we're doing. We've modified our procedure a little bit in how we do this. And we basically tuck the lymphatics into a vein. We secure that all the way around. We remove that initial stitch. We turn on the filter, and now you can see the fluorescein just starting to make its way into the vein. This woman also needed a breast reconstruction, so I put a tissue expander in her, came back an hour later, and you can now see that vein is filled with arm lymph. This is where we did the anastomosis, and this is this. So for decades, we've just been leaving that to just drain, develop seromas, increased risk of lymphedema, scar down, block the lymphatic system, and now we just give it a new home and a way to drain. We've recently published, we actually have a Facebook Live event tomorrow through our main journal, which is Plastic and Reconstructive Surgery. It's the most competitive journal you can get your work published in our field. And so this was published, and we went through our entire experience of performing this at the Boston Lymphatic Center. And I just want to show you here, the majority of our patients got adjuvant radiotherapy, of which the majority was regional lymph node radiation. And we had a total of 14 nodes removed, a median of 14 nodes removed. So these were true axillary lymph node dissections. And I bring this up because the literature is very clear on this. With these risk factors, the baseline rate of lymphedema should be 26 to 33%. I don't think anybody who studies lymphatics is going to argue with me on that. And then, so these are our results. These are all 90 patients we ended up reporting on. Every circle represents a visit in our clinic with Kathy and her team. Clear circle represents they did not meet the criteria for lymphedema. A black circle means they did. So in essence, in a median follow-up of 17 months, we had a lymphedema rate of 9%, or 8 patients. And so this was, again, the symposium has played such a big role in the evolution of our ideas and thoughts. This was 2018 at the Merck Center where we held our symposium. That's Suzanne Klimberg, who came to speak, Lisa Spiegel, who was a breast surgeon who I started doing this with down in Florida, and Dr. James, who is Ted James, who's a chief of breast here at Beth Israel and who I perform the majority of these procedures with. Okay, so in conclusion, there is no cure for lymphedema. Again, I don't say that to hurt patients, but I say that to make sure they understand when they come to see us that we are going to help them with quality of life, but likely we're not going to cure them. We need to focus on early detection and prevention, and I do believe surgical options significantly improve quality of life for our patients. Again, I want to thank the core clinical team, our research team, our funding from the NIH. You guys heard from James yesterday, and you see the passion that our team has on the research side. And thanks again. If you're interested in learning more, you can go to the website. And the book's also available for free online if you go to this QR code. But again, if you want a print copy, I actually haven't checked, Megan. It's still on Amazon. Okay, go check it out, and you can get print copies on Amazon. Thank you, and I'd love to take questions if there are any.
Do you ever do the debulking procedure and one of the other procedures simultaneously? And if you do, what does that patient look like?
Yeah, great question. So we generally, actually the answer is no. We have not done that yet. okay? So why not? Well, the post-op protocols, which I know Kathy's about to get up and talk about, are widely different on each of these. So with a lymph node transplant, you can't compress a lymph node transplant for a minimum of 3 weeks because we don't want to get any clots. You know, any free flap we do, we don't want to compress them. With debulking, you got to compress them right away. Their class 3 Alvarex goes on the table. We're like, you know, struggling to get it on, but we get it on all these patients. So for that reason, we don't do those two procedures together. The lymphovenous bypass and debulking procedure, we have started talking about internally, saying, why don't we consider doing these at times together? And the reason we're saying that is our algorithm has been debulk, and then come back into physiologic. And doing a lymphovenous bypass in a debulked patient is very challenging. And so are we not missing an opportunity potentially to do this at the time of the debulking when we're dealing with a kind of a virgin territory where the tissues are not scarred and whatnot? So we're discussing that, but for now we have left things very separate. It's helped also clarify what we're delivering to our patients and what's doing what, and it's helped me advise patients better, for sure. Yeah, thank you.
How do you overcome the challenge of sizing the class 3 garment that you're going to be putting on the limb, on the operating table?
Yeah, so Kathy, do you want me to defer? Are you probably going to talk about this in your talk, or? No, you.
I can also answer it. I have a mic.
Yeah? Oh, yeah, there you are. Go, Katrina, go.
So we have a fitter, and she actually will measure the unaffected leg or arm because the goal is to get it to the same size as their other limb.
Yeah, and I think you guys do take certain areas and give them a little extra relief because you can get pressure sores, unfortunately, and we've learned through our experience that can happen.
Yeah, so around like the wrist and ankle, we'll take it on the affected arm or leg.
Has anyone ever recommended 24/7? I've had some patients, it just sort of happens to happen that they'll wear their garments day and night and it works out fine for them. Other people, they run into trouble in the antecubital fossa or in the knee. Is it something that people are doing more instead of a nighttime garment?
Sorry.
I guess the question is, do people recommend flat knit garments day and night for their patients, non-surgical patients too? Since it seems to be okay for the post-surgical, is this an easier direction for us to think about going in a safe way somehow?
I'm going to take that. Just because, yeah, I was going to talk about that anyway. Part of the protocol for post-operatively for liposuction is to wear the flat knit garment day and night. And we can do that, well, because Boston set up that protocol and has data from, more than 20 years follow-up for all of his patients. And the key is making sure you get a good fit so that it's not chafing, causing any pressure areas, and that the patient gets the garment on correctly and repositions it correctly. The thickness of the material bridges skin folds so that it doesn't cut into the crevices like a circular knit would. So you don't have that tourniqueting effect when they're wearing it overnight. So it's critical that the patient knows how to wear it correctly and that we get a good fit. And Borson also established a protocol of what he calls controlled compression therapy. And they use flat knit garments of progressively reduced circumference over time to reduce the edema. And they use flat knit garments, all the time, day and night. So even apart from the liposuction, he would recommend using that. So for some of our patients, we have used that for when a traditional night garment doesn't provide enough compression, we might use flat knit garments. If we're using a traditional night garment and then bandage over it to add compression and that's still not enough, we might use a higher level of compression with a flat knit. It has the hold, it has the strength to resist so that it holds the compression a little bit better. At night, you typically don't need as high a level of compression, and even in our postoperative garments, somebody with lower extremity lymphedema is wearing a class 3 waist high and a class 2 thigh high all day. They take that second layer off at night and just go to sleep with the class 3. So they wouldn't be able to tolerate the 2 layers.
Thank you. So as I alluded to, in March, I had my right leg had the debulking, and I've had lymphedema for almost 40 years, and I used to wear a custom flat knit 3 Jobst forever, last 20 plus years, and at night, I can't even remember what's the quilted thing, the tribute. Thank you. I wore a tribute and then wrapped over the tribute to give more compression. And now, as Kathy said, I had 13 pounds removed. It is life-changing. And I do the full 3 and then a class 2 over it. And I'm sleeping, I couldn't understand that you're making me sleep now in a 3. And I'm like, well, what about the tribute? And I was always told you're not supposed to sleep in a flat knit, and, but it's such a relief that I don't have to put on this, a tribute that is so bulky. And it's just so weird, these little teeny things. So I'm a side sleeper, and the tribute is like wearing an oven mitt, right? This bulky oven mitt. And so I always had to sleep with my legs, separated because it was so bulky, and then I had the wraps and all this stuff. And now, once it's recovering, now I can sleep with my legs on top of each other laterally, And I'm like, wow, this is probably how a lot of people sleep. It's just the things that go through your mind. You're like, huh, this is kind of cool, So, and it works. It does keep me reduced. And so another question, is it okay to wear the class 2 on top of it? Do I have to take it off at night? Anybody?
I know we advise not to, but I don't know if
It's an awful lot of compression, so I would say individually, I would make that recommendation a blanket recommendation. It's a lot of compression for people to wear at night. I would need to make sure the skin is going to be okay with that. So that would be an individual variation.
Louise, any thoughts on you? I know we approach patients very similar from a surgical standpoint. Do you have any different recommendations there? Nope.
No, we follow Brawson's protocol as well. As far as just make a comment about the day-night. Before we had the invention of nighttime garments, we used to have patients wearing flat knit, custom-made garments in the past. In Australia, our climate is hot in the summer. What we tend to talk to the patient, not surgical patients, our protocol is 24/7 surgical, but your non-surgical patients, we say to them, if you don't wear a garment overnight, does your condition worsen? If it does, you need to wear garments 24/7. If you find that overnight you don't get worse symptoms, then some of our patients don't necessarily wear a garment overnight. So it just varies.
I was wondering if these procedures are covered by Medicare or Medicaid?
Yeah, so they are covered by Medicare, Medicaid. In fact, we see a lot of patients with Medicare, Medicaid, because other surgeons who are in a more private setting aren't able to take on those patients. We're in an academic setting, so, and I have to just say, Beth Israel Deaconess is a center that has believed in this. They've taken it on the chin financially, and we are working on reimbursements, but the short answer is yes. We will absolutely see pretty much anybody, even if you don't have insurance. We have to get you insurance, like Medicaid or whatnot, but we will operate on patients. We just want to help this community.
Correct me if I'm wrong, if I misheard you earlier, but I think you said primary lymphedema in some of your harder cases in males with the debulking procedure. So what kind of outcomes do you see? Like why is primary part of your harder cases versus even just secondary?
Yeah, so we don't know. I was actually, part of what I had to do yesterday was a scientific conference, and they've noticed in the transgender community, in doing certain surgeries, certain hormones, testosterone, are potentially affecting healing and creating more fibrosis. And so what we have noticed anecdotally in our male patients when we go in is the fat comes out white. Like it should be gold, like golden. It comes out white. And my hunch is that it's a testosterone effect on the fat that's making it so hard for us to break up and get out. So there's the physical component of it, of just getting it out. And then I've noticed, and Kathy, please jump in if you feel this or you want to add to this, but I think we've had trouble controlling the fluid on these patients. Like we've put them in maximal compression and they still fill with fluid. We've had a lot of, we've only had less than a handful of patients with these 3 risk factors, but it is something we're very aware of and we counsel patients on if they meet those criteria. Great, thank you.